Nasuri, she's around. Noor Nasuri, she is not here. So we can move to the next, speaker, Dr. Diva. Diva is going to present a case with the title of betrayal of the fellow eye.
Fellow eye. Yeah, thank you so much. So I'll jump right to the case. So 30-year-old male patient presented to us with sudden deterioration in the left eye. With mild pain in the right eye. He had some history of treatment in the right eye elsewhere, but didn't have the papers with him at the moment. But there were no history of trauma as such or any proper surgery that was performed. So on examination, the right eye was no pale, but both the eyes had signs of inflammation. We could see circumcorneal congestion, KP, cells and flare, and left eye also had similar findings. The IOP was normal. So we did certain investigations, the fundus photo, angiography and OCT. So the photograph showed, it's not very clear here, but showed multiple yellowish. The left eye showed multiple yellowish whitish lesions and some multifocal exudative retinal detachment and a hyperemic disc. Similarly, on FFA, we could see multifocal punctate hyperfluorescent spots in the early venous phase, which continued to late leakage. And OCT saw this huge retinal elevation because like an exudative detachment that was present. So, of course, there were a lot of things that come to mind considering the Indian population. We did a battery of tests. Everything came out to be negative. We focused more on the history that he was talking about, what treatment he had undergone recently. So we were able to contact the earlier doctors who were treating that boy. And in the right eye was a Coats disease. He had Coats disease in the right eye, for which ended up as a neovascular glaucoma and turned out to be a blind eye. And DLCP was performed in that eye to reduce the pressures. So then we made a provisional diagnosis of cyclophotocoagulation induced sympathetic ophthalmitis, in this case secondary to Coats disease with NBG patient. We put the patient on IVMP 500 milligram 3 days and then to oral steroids, and slowly we saw that the OCT became quite normal and the patient regained his vision, and the macula also started looking normal. The patient had pain and discomfort, so it became like a painful blind eye in the right eye. So we went ahead and enucleated the eye and sent that eye for histopathology and immunohistochemistry in that. So these are the findings that we sent to our ocular pathologist. So we saw, this is the right eye, which shows a lot of thickness in the choroid with grayish-white condensed exudates. Microscopy under HNE showed inflammation of the limbus with addition of the iris to the peripheral part of the cornea, which was probably the site where the cyclophotocoagulation was done. We could also see some telangiectatic vessels with exudation, cholesterol clefts, all consistent with Coats disease. And we could also see lymphocytic infiltration involving the choroid, sparing the choriocapillaries. So all these things, made, it's of course a clinical diagnosis at the end of the day, but it sort of confirmed what we were talking about. So sympathetic ophthalmitis is a very rare, we see it less often now. A bilateral panuveitis kind of a picture where there's the exciting eye and the sympathizing eye. And the onset can be anywhere from 5 days to as much as 66 years that has been reported in literature. So any surgery basically can, lead to this. Coming to our case, cyclodestructive procedures, it has been reported, but very rarely it is there in the literature. So in our patient, we hypothesized that the patient had Coats disease, which increases the vascular permeability and the inflammatory cells, and might promote the presentation of the uveal autoantigen to the lymphocytes, and along with the DLCP that was done could lead to sympathetic ophthalmia, which has been reported with other laser cyclocoagulation procedures as well. So this we published in the Indian Journal of Ophthalmology a few years back. So as we are surgeons, we should be aware of these atypical inciting factors for sympathetic ophthalmitis as well. Thank you so much.
Thank you, doctors. It's rare. We published 12 cases of CBC with symptomatic ophthalmia, being for lymphocytic glaucoma, most of them, or cases of uncontrolled glaucoma, and ended by this symptomatic ophthalmia. It's one of the complications, but we have to be aware about them. But
Yes.
nowadays, I think they are having selective types of
Yes,
populations, or they do, what we call it, a micropulse, which is less and less.
destructive.
But CBC is really where it's one of the well-known cause. So good to to look for such case and you treat on time.
Devkant, excellent presentation. What is the long-term course of this patient? Because generally what happens is, traditionally we are taught that if you enucleate them early, most of the time the inflammation can be brought under control. But if you do a delayed enucleation, even if you enucleate it later in life,
Right.
they'll have a long-drawn course. So ideally, most of these patients of sympathetic ophthalmia will eventually land with IMTs.
So this patient, the procedure was done around 6 to 8 weeks back. So the history was not that long. And the patient is in follow-ups, doing good for the past 2 to 3 years now.
Just on oral steroids?
Yes, initially oral steroids. Okay. Now off steroids, of course.
But there's no recurrence after steroids?
Not yet. Yet.
They don't have trauma. They don't mention that they have surgery.
Gets confusing.
So put in mind that to ask about possibility of any, photocoagulations in general, that's important. Why? Because cyclophotocoagulation is work in the cellular body, and there is elaborate more of endothelial cells that might be the in relation to that. Doctor?
The thing is, normally when you have uveal tissue exposed, that's the time we talk about sympathetic ophthalmia. But there are cases, as you said, where there may not be exposure of the globe is still intact,
right,
and you can still have inflammation which can precipitate and cause a sympathetic ophthalmia.
So I think that's the takeaway
message which we need to understand. Thank you.
Thank you.
I present the